A 25-year-old man presents with an acute history of sudden intense vertigo on walking, with loss of balance affecting his right side and pain in the right ear. There is no associated deafness or tinnitus. On examination, he has a nystagmus with rapid component to the right. Which one of the following is a likely diagnosis? It's so acute. Loss of balance, right side. Pain in the right ear. No associated deafness, tinnitus. It's the vestibular nerve that is affected. Nystagmus with rapid component to the right. Vestibular. Let's look at the other options. Cerebellopontine angle tumor wouldn't be so acute because the compression is gradual, right? Meniere's disease. Meniere's disease is too much endolymph in the cochlea, right? I think so. Of course, tinnitus. Probably wouldn't be so acute onset. Will affect your hearing, if I'm not mistaken. Vestibular neuronitis, since it's not, the auditory nerve is not affected, so vestibular nerve is affected. Vertebrobasilar ischemia. Vertebrobasilar, where is that? Basilar artery, is it in the pons? Vertebrobasilar. Vertebral arteries. Posterior circulation, is it? Something to do with posterior circulation in the pons. It might cause motor symptoms in this case, I guess. Paroxysmal positional vertigo. There's no mention of sudden turning of the head. And there's pain. Pain. Which one of these can cause pain? Ischemia can cause pain. Neuronitis can cause pain, I guess. Yep. So hearing is normal in vestibular neuronitis. Sudden and near complete loss of vestibular function in a young patient is suggestive of vestibular neuronitis, a condition assumed due to a self-limiting viral infection of the vestibular nerve. The inner ear becomes swollen and painful. The vestibular nerve carries the balance signals from the inner ear to the brain, and as a result of the inflammation, patients will experience vertigo. Typically, vestibular neuronitis is unilateral and does not affect hearing. Vertigo is most severe initially and usually subsides gradually over a few days. But positional vertigo on head movement may persist for several weeks. Treatment is expectant with reassurance. Recurrent vertigo attacks lasting hours or days. Fluency of vomiting may be present. Horizontal movements usually present. No hearing loss or tinnitus. Labyrinthitis will affect the hearing as well, right? Posterior circulation stroke. What's the HINTS exam? I think that was a YouTube video on this.
The HINTS exam in Vertigo. This video is about who to perform the HINTS exam on, how to perform it, and how to interpret the findings. The HINTS exam is used when a patient presents with many hours or days of ongoing continuous vertigo, nausea, and/or vomiting, some difficulty walking. Their vertigo gets worse when they change position, such as going from lying to standing, and importantly, you can observe spontaneous nystagmus. Most of these patients will be suffering from vestibular neuritis, a benign cause, but some will be having a stroke. The HINTS exam is used to reliably diagnose vestibular neuritis and thus rule out stroke. There are three components to the HINTS exam: nystagmus, test of vertical skew, and the head impulse test. Nystagmus you observe in primary gaze where they're looking straight ahead, and in lateral gaze where you ask them to look to the left and right. In this normal volunteer, she has no nystagmus. Now, when you ask them to look laterally, they might fixate on your finger if you put it there or something on the wall. So in order to take away fixation, which can suppress the nystagmus seen in vestibular neuritis, you can place a piece of paper between their head and the wall and ask them to look at the wall as if the paper isn't there. That takes away fixation, and you might see nystagmus, which you wouldn't see without the piece of paper. In this patient with vestibular neuritis, observe his nystagmus. Flip to the left again. And to the middle with the right. Here it is again. When he looks to the left, his nystagmus increases. It's left beating, and there's a rotatory component towards the left, and it increases when he looks to the left. You can see the torsional component. And when he looks to the right, it lessens, but the fast component is still towards the left. So it's unidirectional nystagmus. It doesn't change direction. In the HINTS exam, this is reassuring. Compare that to this lady, who when she looks to the right, she has small horizontal nystagmus with the fast component to the right. I showed this short clip twice just to see the little right word beating nystagmus. And then when she moves more central and to the left, you can definitely see that her nystagmus is now beating towards the left. So she has direction changing nystagmus or bidirectional nystagmus, and that's worrisome in the HINTS exam. The next component of the HINTS exam is the test of Skew. You observe this by doing the cover-uncover test. You simply take your hand and place it over the patient's eye and move it to cover the other eye and observe if there's any vertical movement of the eye when it's uncovered. In this patient, observe how when I first take away my hand from his right eye, that the right eye will go medially and upward. And then when I take my hand away from the left eye, it goes immediately and downward. It gets a little less as we go along, but there's definitely some vertical skew deviation, which is worrisome in the HINTS exam. Upward and medially, downward and medially, upward again. So this abnormal vertical skew deviation is worrisome in the HINTS exam. The head impulse test will be abnormal if you have vestibular neuritis. The head impulse test is looking to see if you have a nerve problem. And if you have a nerve problem, you probably don't have a brain problem. So it's a little counterintuitive in that an abnormal finding is a good finding. In order to perform the head impulse test, hold onto their skull, have them look at your nose or the camera, and then move their head back and forth until you're sure that their neck muscles are relaxed, and then in a random fashion, move their head briskly to the midline from maybe 20 degrees out. What you're looking for is an abnormal catch-up saccade, which I'll demonstrate shortly after this normal volunteer. So again, holding onto the skull, moving the head slowly to relax them, and then moving their head briskly to the center and looking for any abnormal movements. Her eyes remain completely fixed on the camera, and that's a normal thing, which in a normal person is good. If she had a acute vertigo lasting hours and days in nystagmus, it would be bad. Here is an abnormal head impulse test. Notice how this man, initially you can see some nystagmus when he looks to the left beating nystagmus. Then when his head is turned to the right, you'll see the catch-up saccade. This is normal, that one. The next one will be the catch-up saccade. Did you see how there's a larger movement of the eye from the right to the back to the midline? That's an abnormal head impulse test, which is reassuring in the HINTS exam because you're showing that he has a nerve problem, probably doesn't have a brain problem. Here's another one. Again, when his head is moved to the left this time, sorry, to the right, then you have an abnormal head impulse. This is actually normal, just a few beats of nystagmus. One more time to the right, which is abnormal. There's a catch-up saccade. He almost did it while his head was being turned, but there was an abnormal catch-up saccade. So that's reassuring HINTS exam because he has an abnormal head impulse test. And this lady who we saw earlier with the direction changing nystagmus, she has a rock-solid head impulse test, which is worrisome because she has acute vertigo and nystagmus, and we can't find a nerve problem. So she probably has a brain problem, which she did. So a reassuring HINTS exam, you have to have all of three components. You have to have unidirectional nystagmus, no vertical skew deviation, and an abnormal head impulse test. A worrisome hints exam if you have any of the following: direction changing nystagmus, an abnormal test of skew, or a normal head impulse test. Just to recap an important point, which patients do you perform the hints exam on?
Posterior circulation, sure. Management of vestibular neuronitis. So just to recap, hints exam, you have three components. You have the nystagmus, you have vertigo skew, and you have head impulse test. So if the nystagmus is unilateral, means you ask him to look at the left, then the nystagmus is left beating. When they look at the right, the nystagmus is still left beating. That is pointing towards vestibular neuronitis. However, if the nystagmus changes position, the fast component of the nystagmus changes directions, then you have to suspect a brain pathology. The second component is a vertical skew. So you block one eye after the other. It's sort of like a strabismus test, and see if the pupil moves, the eye points towards any direction, up and medial or down and medial. It's a vertical skew. If this present, is worrisome, suggesting a brain pathology. And the third one is a head impulse test. This one, if it's positive, then it's reassuring in the sense that it's a nerve problem and not a brain problem. So you make sure the patient's neck is loose by moving the head left and right slowly, and then suddenly moving it back to midline, and you observe if there's any delay or catch-up phase in the movement of the eyes. Okay, that's your hints examination. I don't wonder why it's called hints. H is for head impulse. HI is for head impulse, N is for nystagmus, and T is for vertical skew, or what is it also known as? Test of skew. Test of vertical skew. Okay, HI and TS. Cool. Management vestibular rehabilitation exercise are the preferred treatment for patients who experience chronic symptoms. Buccal intramuscular prochlorperazine is often used to provide rapid relief for severe cases. Short course of prochlorperazine or an antihistamine buccal intramuscular prochlorperazine is often used to provide rapid relief for some cases. Prochlorperazine antihistamine, isn't it? No, it's a dopamine antagonist, antipsychotic. It's a neuroleptic. The video is here. Okay, that's good. Likely one is vestibular neuronitis, but you need to rule out a posterior circulation stroke, which is vertebropasilar ischemia. This internal carotid artery, this is a vertebral artery. This is a spinal artery, this is a basilar artery. So vertebropasilar ischemia is posterior circulation stroke. The pond area. Ponds. Alright.